Good afternoon and welcome. My name is Joan Williamson, and on behalf of the Virginia Hospital and Healthcare Association, the Center for Healthcare Excellence, we are pleased to host this important webinar on Neonatal Abstinence Syndrome, public health reporting in Virginia, and information on the Virginia Neonatal Perinatal Collaborative and the work with the Vermont Oxford Network's Neonatal Abstinence Syndrome Quality Improvement Project. Today's webinar is being repeated Wednesday and Thursday of this week to maximize access and to provide question and answer clarification opportunity for Virginia healthcare professionals. The webinar is being recorded and will be posted on the VHHA website and on the VNPC, Virginia Neonatal Perinatal Collaborative website as well. That website will be functioning soon, but it won't be immediately, it won't be available immediately. The first part of the webinar, Ann Zahner from the Virginia Department of Health will discuss the requirements of the new NAS mandatory reporting. Ann is the neonatal abstinence syndrome epidemiology subject matter expert for the Virginia Department of Health. And in the second part of the webinar, Dr. Jenny Fox will explain the work of the Virginia Neonatal Perinatal Collaborative and the NAS Neonatal Abstinence Syndrome Vermont Oxford Network Quality Improvement Project. Dr. Fox is a community neonatologist here in Richmond, and she is also one of the leaders of the Virginia Neonatal Perinatal Collaborative Neonatal Abstinence Syndrome Work Group. If you will save your questions to the end, we want to have our speakers have ample opportunity for their presentations, and we will have a good opportunity at the end to answer your questions, and so we'll do that at the end. I want to go through a couple housekeeping items first before we get started, just in case you are new to this webinar platform. Slides were sent out this morning to those that were registered. If you registered late, you can access slides also from the handout section on the GoToWebinar platform. This webinar is being recorded so it can be shared with others who are unable to attend live. We do ask that you please dial in using the telephone option if you are able. You will be prompted to enter your audio PIN, and this will allow us to have a discussion at the conclusion of the webinar. At this time, all participants are muted, and all panelists are unmuted. If you do have a question, we ask that you hold that question until the end of the webinar. You may ask a question by simply typing in your question into the question box located on the tab menu. And with that, I'd like to first give you Ann Zahner, epidemiologist with the Division of Public Health, Virginia Department of Health. Ann, welcome.
Thank you. Good afternoon. Thanks for being here today. As I was introduced, I'm Ann Zahner, an epidemiologist with the Virginia Department of Health. I manage our neonatal abstinence syndrome data, and today I'll be reviewing the details of our new neonatal abstinence syndrome public health case reporting system with you today. We'll also have time at the very end for questions you may have, so please stay with us for that. Briefly today, I'm going to review several topics. First, I will present some of our surveillance data on NAS incidents in Virginia. Then I will discuss Virginia's NAS reporting law, review the NAS public health case reporting tool, highlight the FAQ document we've developed for our NAS surveillance, and at the very end, I'll take questions. Neonatal abstinence syndrome, or NAS, is a condition of drug withdrawal in a newborn that sometimes occurs when mothers use illicit or prescription substances while pregnant. Over the past few years, we've seen a marked increase in the number and rate of NAS cases in Virginia. What you're looking at right now is a NAS incidence trend graph presenting the rate of Nass Diagnosis per 1,000 live resident Virginia births. As you can see, the rate of Nass Diagnosis in 2016 was more than 7 times the rate occurring in 1999. Note the 2016 rate is still provisional as we are still waiting for final certification of the number of live resident births that occurred that year, which provides the denominator for the rate. The requirement to report all infants diagnosed with NASS went into effect in November of 2017, following an action by the Board of Health that was directed by House Bill 1467. This public health reporting is intended only as a mechanism for tracking the number of these affected infants, and not for any kind of active case management or prospective tracking of infants over time. It should be noted that what we are asking providers to report are Nass diagnoses, not the more general category of infants who are born to mothers who abuse substances. Only if an infant receives a Nass diagnosis should that infant be reported to the health department through the online tool I will discuss later. This public health reporting requirement is in addition to the legal requirement for providers to report substance-exposed infants to Virginia DSS. Both reports are now required by law. Just as a kind of a housekeeping matter, DSS and VDH will not share case reports with each other, so separate reports of NASS infants to VDH and substance-exposed infants to VDSS must be made. VDH's public health reporting requirement holds that within 30 days of diagnosis with NASS, physicians and directors of medical care facilities are required to report these infants to VDH through our new online morbidity reporting form. The requirement to report all NASS cases does not depend on the severity of symptoms, the type of treatment, or the substance exposure source. All NASS cases should be reported through the online tool. Furthermore, this reporting requirement falls on Virginia facilities only. So out-of-state facilities caring for Virginia residents are not required to report to VDH at this time. Only one public health report to VDH needs to be made per infant. So care providers should coordinate and establish the lead party for the report. In a given facility, it may make sense to identify one key person to make all NASS reports, such as a manager of a nursing unit or an administrator, to prevent duplication and to ensure one point of contact for NASS reporting for that facility. Now I'm going to talk about our online NASS reporting tool. So NASS case reports can only be made through the online tool that we have set up through the VDH website. This is a new tool, and it is a component of our confidential online morbidity report, which is known in its paper form as an EPI-1. The online reporting system can also be used for other reportable conditions, but in this case, all NASS reports can only come in through the online form and not through the paper version of the EPI-1. The confidential morbidity report is available on the VDH website at the link shown on the slide, and it has been developed in REDCap software to facilitate the rapid, convenient reporting of NASS cases. REDCap is a secure method of conveying these reports to the health department as it sits on a secure VDH server behind a firewall. It therefore meets all public health surveillance data security requirements and is a secure method for transferring this information to the health department. So in the NASS reporting tool, when you've entered the tool, you should note that you cannot exit and re-enter the same record. So you should have all of the NASS case information available when you begin with the report. This is easiest if you have access to the patient record at the time of data entry. If you do not complete all of the information in a NASS case report, that record may not be used for surveillance purposes, as we may not be able to determine with the information provided being incomplete that that is a NASS case report. So it's very important that the fields be filled out as completely as possible with all required information entered. The quality of the data we receive depends on the completeness of the reports we receive through REDCap. Please include the name and contact information for the person making the report and for the facility the infant was hospitalized in, so we can follow up if information is unclear or missing. Again, we will not follow up with the infants or their families themselves, even though identifying information is collected on each infant. These reports are not being used for case management of any sort. Any follow-up we conduct will only be with providers to address issues with data in the reports that might not be fully complete. So the next several slides will review screenshots of the NASS tool, and we'll talk about the data elements captured in each screen of the tool. When you enter the NASS case reporting tool or the confidential online morbidity reporting tool, the first screen you get to identifies this is our reporting tool for reportable conditions. On this page, if you intend to enter a Nass case report, you will need to select the visible Disease Report radio button and then progress through the rest of the screens. The second page asks for the identifying information for the Nass diagnosed infant. Please note, a name is requested, but we recognize that not all infants have formal names at the time of diagnosis. It is acceptable to give a name of Baby Boy Jones or Baby Girl Smith if a first name has not been chosen for the infant at the time of the case report. But please make sure that the identifying information for the infant is as complete as possible. For the contact information and location, please give the mother's residential information, as this is the best information we will receive about where the exposure took place. The bottom of that page collects the remainder of the demographic information about the affected infant. As you scroll through to the next page, on this screen at the top, you are asked to select Neonatal Abstinence Syndrome from the drop-down list of conditions available in this form. Without this selection, your entry will not be recorded as a Nass case report, so it's very important that you select this value if you are reporting a Nass case. The case report is not complete without this value. The rest of this page collects information about the facility and the physician who made this diagnosis. Again, this is the bottom of that screen that asks about the physician's contact information, whether the patient is deceased, and whether the patient was hospitalized for this illness. There is also an optional box to describe any treatment that was received, including the dates of treatment. Scrolling through to the next screen, this is a very important screen in our Nass tool. It asks specifically about the circumstances of the Nass case, and this screen only comes up if you choose that if you select in a previous screen that you are providing a Nass case report. It first asks about the outcomes for the infant, such as whether there are clinical signs and whether they are mild or severe. The second question asks about any diagnostic tests that have been performed, and there's an additional field later in the Nass screening tool where you can enter this diagnostic testing information. The third question asks about other supportive elements for a diagnosis, including maternal history of drug use or maternal or infant screening tests. The fourth question asks about the source of the infant exposure, including whether the drug was prescribed or illicit, and if it was prescribed, if it was for an opioid or a non-opioid. There is an option to select if the source of the exposure is unknown, but the infant does have signs consistent with Nass. We recognize that information about the exposure source may sometimes be unclear at the time of diagnosis, but again, from the date of diagnosis, you have 30 days to make a Nass case report with the health department. So if details of the case are not clear immediately, it is possible to wait to make the Nass case report until all the details are known. The next screen you navigate to accepts information about one or more confirmatory labs that may have been ordered. If you click the radio button at the bottom, you can enter a second or third or fourth lab report, depending on how many labs there may be. And this is the top part of the last screen of the Nass tool. Please note the question at the top is a component of our more general confidential morbidity report and is not a required response for Nass reporting, as Nass presents no known risk situations to other persons. It's okay to leave that field blank, and a Nass case report is complete without responding to the risk situation question. But the other fields in this page are all required, as we would like to know who is making the report on behalf of the facility or provider. This is the last part of the last reporting screen that collects contact information about the clinician making the Nass report. For your reference, there is also a Nass reporting FAQ document that addresses some of the early questions we received about Nass reporting. You can access it on the same webpage as the Nass case report. You can also refer Nass questions to me or to the EpiComments email address given on this slide. My contact information is at the end of this slide deck. Responses to email and phone requests are pretty rapid at this point. We can get back to you fairly quickly, so if you do have a question about the required elements of Nass reporting or the circumstances under which you need to report, please feel free to email the EpiComments email address or to shoot an email to me or give me a phone call, and we'd be glad to respond to your questions. I know they're going to hold questions to the end, and the last slide has my contact information if anybody's interested in following up, or again, the VDH EpiComments email address.
Thank you, Anne. I'm sure there'll probably be some questions for you at the end. And now we'd like to introduce to you Dr. Jenny Fox. And Dr. Jenny Fox is going to speak about the Virginia Neonatal Perinatal Collaborative and the work that they are doing with NAS and the Vermont Oxford Network Quality Improvement Project. Dr. Fox.
Hi, thank you guys so much for having me here today. Let me try to move forward to my slides here. All right, so thank you, Anne, so much for presenting about what the Virginia Department of Health has arranged in doing and collecting all of this data. So a lot of people have been confused because they've been hearing about the VNPC. So the VNPC is a separate organization. It's a Virginia Neonatal Perinatal Collaborative. It actually is the envisionment of Dr. Donald Dunley out of UVA and Dr. Joseph L. Corey out of Children's Hospital of Richmond at VCU. That's one of our obstetricians and a neonatologist that came together and saw this vision that we could get physicians together, nurses, interdisciplinary staff such as physical therapists, speech therapists, nutritionists, get our local leaders and state leaders together as well as parents and other people interested in improving the care for mothers and infants in the state of Virginia. One of the tasks that we were put together as we created this team was to focus on the Neonatal Abstinence Syndrome, and we're very excited now to be able to collaborate with the state and Virginia Department of Health and to utilize the VON, the Vermont Oxford system, in improving outcomes for infants with NAS. So like I said, the Virginia Neonatal Perinatal Collaborative, we have a specific work group that's focused on the neonatal abstinence syndrome. We have a collection of pediatricians, neonatologists, nurse practitioners, social workers, public health workers, all interested in improving health outcomes for mothers with opioid addiction and the care of their infants with NAS. This is the project group members from across the state in different fields, led by Dr. Swanson out of UVA and I, and we are leading the team in working with Vermont Oxford in trying to collect information in how we can improve NAS across the state. So when you hear, there's lots of different V's that we're throwing out. So there's the Virginia Department of Health, the VNPC, and then the Vermont Oxford Network, all different things, but we're all working together for the same cause. So the Vermont Oxford Network, this is a global organization. It's nonprofit. They are dedicated to improving the quality and safety of medical care for infants and their families. In response to the 2012 American Academy of Pediatrics statement calling for standardization of care for infants with neonatal abstinence syndrome, the Vermont Oxford Network came together to develop this NAS Universal Training Program. And the concept is based on providing high reliability care developed based on standardized clinical processes. So when they first rolled out this, they enrolled over 199 centers from across the United States, Canada, and the United Kingdom, and they collaborated in creating different interdisciplinary teams and focused on the AAP recommendations to improve screening for maternal substance use, the use of non-pharmacological treatments for infants with NAS, how to improve scoring for infants with NAS, looking at breastfeeding, looking at pharmacological management, and also how long were different institutions observing infants that were exposed to opioids. And to date, 5 different states have adopted this universal VON training, and I'll discuss some of the things that have come out of this. So the primary project goal, the primary project goal is to use systematic rapid cycles of current evidence-based education and materials to different interdisciplinary teams who are engaged in caring for substance-exposed infants and their families. The project will disseminate evidence-based education and materials, and also will provide support for different institutions to have rapid cycles of uptake of potentially better practices. And the overall goal is the hopes that this will lead to statewide improvement and standardization of the care of NAS in Virginia. So this is a view of what the packet includes. So going from left to right, so the states, the VON will be distributed to different institutions within the state. You'll have your toolkit, your materials, your audits for statewide improvement. We'll go through several rapid cycles of different evidence-based practices. And again, those based practices are based on the experiences of other centers. We'll collaborate within centers of the state to see what centers are doing which different techniques, what's working for people, what's not working for people. And with this collaboration, we hope to learn from each other to see what works best for our state. The different resources that we'll get is we'll get a toolkit, we'll get standardized audits across the state, we'll get different lessons that will be provided to all of the different centers, and these are all evidence-based practices that will be shared across all the centers. And then the hope is that we can collectively raise the standard of care for these infants and improve the quality of care for them, decrease their length of stay, decrease their length of need for pharmacological treatment, and hopefully will decrease the need for prescription medications upon the infant's discharge. So to date, we have over 50 hospitals that have enrolled to join us across Virginia in becoming part of the VNPC project utilizing the VON NAS Universal Training Program. There are about 4 to 7 institutions that we know of that we have not been able to onboard yet, but if you are in a center and you do not see your name on this list, but you are interested in participating, please let us know. So what does it mean once we're getting started and getting onboarded? So a member of our group will reach out to your center, and we will need your help to identify a VON champion and a VON Day data collector. So the VON champion is the person who will be essentially the cheerleader for your hospital. There'll be the contact person who will help to lead the team, get a team together, promote the webinars, promote the audits, and help to make sure that the necessary people are trained to be part of this project. The VON Day data collector will be a person who is well-versed and trained to collect the data and to perform the chart extractions. So VON will actually lead them in training on how to do the online audits. Once these people are identified, we need your center to fill out the enrollment form with their contact information so we can make sure that they can get the proper packets in the training, and then place that on your university or your institutional letterhead and send that to either the project work group representative that's working with you, or you can send it directly to Shannon Purcell, who is the Maternal and Infant Health Coordinator with the VNPC, and her contact information is at the bottom of the page. Once all the hospitals are onboarded, the next step will be to obtain the human subjects approval and data use agreement. Since this is a quality improvement project, this is typically expedited by the IRB. The institutions that are listed right here, they are already a part of the VON process, so they will not need to do this, but the VNPC will assist your hospital if you're not on this list in a template letter to your IRB to help expedite this process. Once you've become part of the VON program, you'll have access to these several tools to help create your team to get going. It includes Microlessons, there are toolkits, there's quality improvement, family-centered care resources, discussion forums, abstracts and improvement stories, as well as poster boards of successes from other institutions that have already gone through this process. This is an example of several of the different microlessons. The microlessons can be anywhere from 20 minutes to sometimes some of them are 45 to 60 minutes in length, but they all provide great information and standardized education to be shared with your institution and all of your interdisciplinary team members. So who should be on your interdisciplinary team and part of this training? We recommend that you have your neonatologists, pediatricians, obstetricians, midwives, residents, fellows, any provider that's going to be taking care of infants with NAS or mothers that are planning on having infants who are exposed to opioids. Any of the nurses that will be taking care of these mother-infant dyads and the step-down units and the NICUs, or any other pediatric or alternative care settings. Any social workers or discharge coordinators, any physical therapists, occupational therapists, or developmental follow-up specialists, unit educators, clinical nursing leaders, leaders in any of the settings that are caring for these patients should be involved in your team. This is an example of the toolkit that will get sent out. It provides several of the potentially better practices for NAS care. It will discuss what are some of the recommendations for how your institution can provide better care, and it will be outlined on how you can look at your institution's current management and try to develop ways to improve your practice of care. So this is a timeline. This was based off of the Vermont Oxford Network Collaborative from 2012 to 2014. When I discussed there was over 199 centers that initially took part in this collaborative in trying to improve their care. And this is an example of what it looked like, their timeline. So from when they first started enrolling patients in 2012 and looking at their baseline data, and then about every 3 months, they reevaluated after they started implementing potentially better practices. Typical audits will look at all your discharged infants that had been treated for NAS in the 3 months prior to an audit. But if your center has particularly high volume of infants, usually we'll just look at the recent 30 patients that had been discharged prior to the audit. So this is an example of what the results will look like. All of the hospitals will be de-identified, and only the individual hospital will know their own data. Statewide hospital data will be shared with all the participating hospitals to help determine the best practices for the state. And then together we'll put together recommendations that will be helpful to standardize care for the state and to ensure the best care is provided to all of our patients. So looking at the Vaughan data that was published in 2016. So you can see that as they did their audits over the course of time, they increased the maternal substance use screen. They increased the evaluation and treatment of substance-exposed infants. They increased their standardized NAS scoring, their non-pharmacological, as well as their pharmacological treatment for NAS. And then overall, they improved their breastfeeding for their infants with NAS. The other thing that they had focused on at that time was the LOT as the length of treatment and the length of stay. And their goal was to decrease length of treatment, and you can see that they were significantly able to decrease their length of stay during that time. So we're very excited to start collecting our data and moving forward to see what our different centers across the state are doing, how can we improve our care for our patients, and how can we all work together to make sure that all of our infants get the best resources and the best care possible. If any of you have any questions, you can always contact Dr. Swanson or myself. Our information is here, or Shannon Purcell's information is also at the bottom. Thank you very much.
Thank you, Dr. Fox. That was great. We now have lots of time for questions. And so if you will type in your questions in the chat box, we already have some questions there, and I'll read those. and we can get started with our discussion. And so the first question is, maybe you will address this, but a baby with no clinical signs of withdrawal does not have NAS, technically speaking. So are you really asking us to report exposures, not just those that have clinical diagnostic signs or symptoms of NAS? That was one of the questions. I guess, Anne, this probably is a question for you.
So the way that the law is written, we are asking for Nass diagnoses. So only Nass diagnoses should be reported. Whatever criteria are clinically being used at your facility to determine those diagnoses are up for your clinical staff to determine, but we are asking for Nass diagnoses to be reported, not the entire universe of substance-exposed infants. So at the time that a Nass diagnosis occurs, that is what we are requesting. We understand that there may be infants who are born who are substance exposed, but who do not, in clinical determination, have Nass, and it is fine not to report those infants. The requirement under the law is to report Nass diagnoses only.
Great, and this is another question probably for you as well. For an infant who is diagnosed with Nass, there needs to be an exposure and symptoms of withdrawal. This diagnosis is fairly subjective. Can you provide guidance on making the diagnosis for Nass? Is there a threshold for symptoms that you recommend to make the diagnosis?
So it's, generally speaking, it's not within my scope of practice to be able to determine, to be able to give information about how a diagnosis should be made. That would be up to the clinician to decide, and I do recognize that there is some subjectivity to that diagnosis. If it's a syndrome and it is not something for which there is a definitive diagnostic test, I wish I could give more guidance on that, but that is up to a clinical determination that a Nass diagnosis is relevant and is valid for that infant. So I wish I could give better guidance, but that's just not within my scope of practice as an epidemiologist.
And I might be able to help you out here a little bit, Anne. So as far as when the Vermont Oxford Network, when we start collecting data with the VNPC, so a lot of that we can look at how the state's doing that as well, because different institutions, that was a big question, is how are people diagnosing? What type of scoring tool are people using to make the diagnosis? At what threshold are different people treating the symptom? And so part of the data that will be collected with Vaughn will be, how are you screening for your patients? What symptoms are you utilizing? What scoring system are you utilizing to make the diagnosis? So I don't know if that's helpful to answer that question.
Thank you, Dr. Falk. We have another question. There's a lot of questions coming in. If your baby's Nass is increased, we transfer those babies to a higher level of care hospital. Who is to report, birth hospital or the hospital they are transferred to for Nass?
I would say that those hospitals, this is Anne, I would say that those hospitals should closely coordinate with each other. We do have a mechanism for determining if a duplicate report has been filed by more than one facility, because there is identifying information in the Nass tool. And so we would have the infant's date of birth, we would have where they were hospitalized, we would have their name and the maternal contact information and some information to follow up on infant with a provider. But I would say that anyone providing care for an infant, whether that is within the same facility or facility to facility, should coordinate with all of the providers to figure out who has made the Nass case report.
Thank you, Anne. And we have another question. When can we expect being able to utilize the Vaughn Nass Toolkit and educational material?
That's a great question. So right now we're trying to, as a group, onboard all of the hospitals, and once we can get all of the hospitals onboarded, we can disseminate the toolkit across the state. So we're in the process right now of onboarding.
And Dr. Fox, this is Joan again. Would you like to just reiterate again for those hospitals that may not have already onboarded, what steps might they take?
Yes. So if you have been contacted by one of our representatives in our project work group, work with them to identify your VND champion and your VND data collector, and that information, their contact information, needs to be completed on the roll form and then submitted to either your representative or to Shannon Purcell. And once that's collected, then we can submit all of those together as a packet, and then we can start getting that packet to come through to be released to the state.
Thank you. And we have another question. What are the current recommendations for performing drug screens on mothers on admission to L&D units? I don't know who was the best one. Yeah, let me repeat that question. What are the current recommendations for performing drug screens on mothers on admission to L&D units?
So I know, this is Dr. Fox. So there is no right now national recommendation on universally performing drug screens. I know every institution is different in how they do that. So that is another piece of information that we would like to gather on how are different people performing drug screens. Are they doing urine drug screens? Are they doing universal meconium drug screens or cord blood drug screens on all their babies? It's very different based on the different institution. And so that would be another piece of information that we hope to obtain through this study on what different places are doing, and really create recommendations on what will the best practice be.
Thank you. We have another question. Does Nass only apply to opioids?
So do you want me to answer this one, Ann? So yes, it does. Opioids, we know the symptoms that babies display after they've been exposed in utero to opioids. This is one of those that we know that there's treatment available for it, and that is why we're so focused on it. You can have in utero drug exposure that causes similar symptoms if you're exposed to, per se, cocaine, or you're exposed to marijuana or tobacco. However, those symptoms aren't the ones that we expect to be treated with methadone or morphine or the pharmacological treatments that we currently use for NAS.
Thank you, Dr. Fox. We have another question. What is the mandatory Nass reporting go-live date? And I think this is probably one of your questions.
Sure. So that date that it went into effect was November 27th. At any point after on November 27th or after, if you care for an infant that has been diagnosed with Nass, that case report should be made to the health department. There is a 30-day window under which you can make that report, and we do not expect people to go back in their records and report cases from before the 27th of November. So from the 27th of November on, and that case reporting tool has been live on the VDH website from that date.
Thank you. That's another question. The reporting form lists SSRIs. Should these not come off if we're focused on substances which might trigger NAS requiring treatment and methadone, morphine, etc.? Were you able to hear that question?
Yes. So this is Ann. So that tool was modified from a tool that is currently in place and is being used in Tennessee. So we based it off of their model of what they collect, recognizing that some of the NAS cases that get reported to the health department may or may not be for opioids, and the substance exposure may be more broad than that. At the time that we can filter out these cases on our end in the surveillance, we will take a closer look at what people are reporting in there, but recognizing that sometimes those diagnoses do get made for substances other than opioids, and not wanting to narrow the field of those Nass diagnoses too unnecessarily. Again, with that reporting tool that was in place in Tennessee that they've been using for a number of years with some good feedback about it being a valid reporting tool, we were relying on some of that groundwork already being done, and so those questions were imported directly from that Nass case reporting tool that Tennessee uses. We may, over time, decide to narrow the focus of it, but we were trying to capture broadly what people might be reporting as Nass.
And this is probably for my benefit. I don't know if anyone else's, but could you clarify SSRIs?
I believe that stands for selective serotonin reuptake inhibitor. It's a class of antidepressant.
Thank you, Anne. We have, I think that is the last question. We'll give a couple minutes to see if any more questions come in. And while we're waiting for any other questions, I will say that we will push out the presentations, the PDF presentations to you, everyone who is registered, and probably within a week or maybe 2 weeks, we will have these posted on the VHHA website. We'll probably post all 3 recordings, and then because I think the questions and answers on each one are probably valuable to people to probably listen to. And we'll send out the link so you can access those recordings. We'll also be thinking of other ways that we can push this information out to folks. And I don't see any more questions coming in. Dr. Fox or Anne, do you have anything else you'd like to add?
No, I would encourage people to reach out to either the FE Comments email address or to my email address or phone number if they have additional questions about the Nass reporting tool. We'd be happy to address any questions that people have, and we have a pretty quick turnaround time on those responses, so please feel free to use both of those.
And if anyone has any concerns or questions about onboarding their institution with the VNPC and with Yvonne, feel free to contact Dr. Swanson or myself or Shannon Purcell.
And everyone, all of this contact information on these slides will be coming your way this afternoon. With that, we thank you for your time. We thank you for your questions, and everyone have a good day. Thank you, Dr. Fox, and thank you, Anne.
Thank you very much.
Thank you.